So my talk was about asking for red cell genotyping in clinical practice, and what I talked about was a case-based approach to talk about 4 different times that in clinical care you would want to do this kind of testing. So one of the cases was about women who have weak D phenotype, and another case was about patients with warm autoantibodies. Another case was about a patient who was on a drug called daratumumab, which causes interference with regular testing. And then the last case was about a pediatric patient who had sickle cell disease. Red cell genotyping should be requested in various clinical situations. I think right now there is a clear case for genotyping if a patient is chronically transfused and is prone to making antibodies. And so one of the most common indications for red cell genotyping is if a patient has sickle cell disease. Some other types, though, are if you have autoimmune hemolytic anemia. And then another category is if a patient is a woman who might be having children and has a weak D phenotype, and in that situation, doing a genotype can clarify if they need Rh immune globulin or not. So I think the future of red cell genotyping is to grow and expand. I think the more we have access to genotyping level data for all sorts of reasons, being able to access that information for the purposes of transfusion is only going to get more as the future increases the amount of genotyping that we do.